Welcome to the pharmaphorum podcast. This is web editor Nicole Raleigh, and today I have with me Paul Romness, President and CEO of OS Therapies, a company focused on the identification, development, and commercialization of treatments for osteosarcoma, or OS, and other solid tumours. Welcome, Paul.
Thank you very much, Nicole.
Hi, this is Chris O'Brien. We'll be right back with the rest of this episode in a moment. I wanted to introduce you to the BioRossi Few and Far Between podcast, hosted by me. Few and Far Between brings you conversations from the front lines of drug development. Each episode features cutting-edge discussions with top biotech innovators and clinical trial industry experts. You can find our episodes on Apple Podcasts, Spotify, and other streaming platforms. Thanks for listening, and now back to the episode.
So today, Paul and I will be discussing bone cancer and the solid tumour space with a special focus on osteosarcoma, which is an extremely challenging and often aggressive cancer that has particular treatment challenges due to location, changing genotypes, and high recurrence rates, and which mostly affects children and young adults under 20 years of age. But before we dive into our central topic, Paul, perhaps you could introduce yourself to listeners and share a little bit more about yourself and your journey to doing what you do today at OS Therapies.
Thank you, Nicole. I guess the biggest thing is that I've been in the industry a very, very long time. And I hope that experience will pay off for our patients in osteosarcoma and other solid tumors. I started my career at Johnson & Johnson, was there for quite a few years, and then went to Amgen and then Boehringer Ingelheim. And I think that prepared me for when my daughter's best friend was diagnosed with osteosarcoma. We had already had an idea of taking other technologies off the shelf that might not have huge indications and repurposing them for diseases. And when we saw the opportunity for osteosarcoma being given up for out licensing, I knew why. And it's just 1,000 cases in the United States, but it's 20,000 cases globally. And it's an extremely deadly cancer. And to your point, Nicole, it's a very challenging cancer that if we're successful in this solid tumor, we believe we can be successful in other solid tumors.
Thank you, Paul. And I'm sorry to hear about that personal experience with your daughter's friend.
She's doing great. She's going to UCLA med school this fall. She'll
Amazing.
Probably be a pediatric oncologist, I would bet. She's very determined, as you might imagine, having survived 9 months of chemo and radiation, and significant surgeries. But she's doing great. She's on our board of directors, and we're making positive out of a real negative.
Absolutely. Inspired and inspiring. Okay, so primary bone cancer is a rare type of cancer, as we've been discussing, that begins in the bones, as opposed to secondary bone cancer, which is spread to the bones from another area in the body. And according to the NHS, there are around 550 new cases diagnosed each year in the UK alone. Meanwhile, the National Cancer Institute has estimated there to be some 3,770 new cases of bone and joint cancer in 2025 in the United States. So my first question, Paul, is can you explain for listeners how bone cancer is thought to start and what generally is known to cause it?
Sure, and your numbers were quite surprising. They were even higher than we anticipated. And thank you for sharing that NCI data with us. We believe that may be the result of some of the effects of COVID and people's immune systems. And as you know, it's the immune system that stops a lot of cancers. And with primary osteosarcoma, it happens after the growth plates of the long bones, specifically proximal tibia, distal femur, proximal humerus, when after puberty, and it happens a little earlier in girls than it does in boys, those growth plates come together, and in those rare cases with osteosarcoma, there's a miscalculation and the tumor seeds there. And if we can catch it early enough, it gets resected from that localized spot. There's usually an implant put in or amputation, but more popular is obviously implants to do limb salvaging. We hope that we may be able to prevent that as well. But then the patients receive 9 months of chemo. It's actually 2 months of chemo, the surgery, and then 7 months of chemo. And with that, you lose about 10% of the patients due to the toxicity of the chemo. Olivia, my daughter's friend who's going to UCLA Med School, spent probably 70-80% of the time in the hospital due to the toxicity of the chemo. But after that, you do your quarterly scans, and then after that, you do your 6 month scans, and 2 years after that, you do your yearly scans, and you just hope that it hasn't metastasized to the lungs and to the brain, which is where a lot of solid tumors metastasize. Just like breast cancer and other solid tumors, you resect, blast the body with chemo. They're these little micrometastases. We call them cancer seeds. They are looking for oxygen and soft tissue. Oxygen to grow and is energy, and soft tissue to land and vascularize. And that's when it starts, those micrometastases start expressing HER2. You can think of them as almost the landing gear into the soft tissue. And that's when survival drops significantly. What we're doing is stimulating the body's immune system by giving it an attenuated or weakened listeria that has a HER2 vector fused to it. So it's out searching for HER2 expressions. And as you know, Cole, there are a lot of cancers that express HER2. And that's where we'll pivot to after our approval with osteosarcoma. But the body reacts violently in immune response and tells the body, and tells specifically the lymph nodes to start secreting T cells that go out and find those little micrometastases. What's particularly cool about our therapy is within 1 hour of receiving the therapy, and very minimal side effects, but side effects you want, of chills and slight fever, which means your immune system's getting fired up. But at hour 4, we shut it down with an antibiotic. But the immune response keeps trucking on. And significant 10, 11, 12 immune responses when the body detects listeria. We shut it down, those T cells go out, and they start looking for those little micrometastases, and they destroy them. And the idea is to prevent those little micrometastases from landing in the lungs in the first place.
Thank you for that, Paul. So just to elucidate slightly on OS Therapies' inroads in this space, OS Therapies was launched in order to meet what is, as we've been explaining, a significant unmet need for new treatments in cancers of the bone in both children and adults. And as you've just been describing, Paul, there is a new treatment for bone cancer that is currently in the FDA process this year, with positive data announced in January based on listeria. OST-HER2 is a bioengineered bacterial immunotherapy. And if we just focus on that for a second, according to a review published in Nature Journal, the relationship between cancer and human microbiota has existed since ancient times. However, bacteria-based cancer immunotherapy, also known as BCIT, was not attempted until the 19th century when one William Coley used live or heat-killed Streptococcus pyogenes and Serratia marcescens to treat patients with inoperable cancer. So, Paul, I was wondering if you could give us a brief overview of the BCIT space and share which type of BCIT, as I believe there are various approaches in the space, that OS Therapies is pursuing.
So we are the only company now globally that has the listeria-based immunotherapy. We believe that listeria, and this technology was developed at the University of Pennsylvania, but we believe that listeria, with its amazing immune reaction, is a great stimulator for the immune system to go out and find foreign objects. As a result, we just recently took over the entire platform, listeria platform, from our licensor. So we're the sole owner of this technology. It was a little ahead of its time. I guess the 19th century approach to it was ahead of its time as well. But that doesn't mean it's not a good idea, as you know. So we believe that it can be very effective. As you mentioned, our clinical trial completed last October. We announced top-line readout data in January, and we'll be announcing the comparator data, which is really important because then you get your p-value and you get the significance of the original data, and we'll be announcing that at the big osteosarcoma meeting here in the United States at the end of June. We're also receiving feedback from the FDA in mid-June that will help us put together our portfolio to submit to the FDA early in the third quarter. So we believe that this data and then the comparator data, once independent third party calculates it, will be demonstrative of strong response for these patients around overall survival and event-free survival.
I mean, it's heartening, basically. I mean, if we go back to the very sort of beginning, or perhaps not the very beginning, the 1800s, since then, what have the developmental stages been like within the BCIT space? What has it gone from to? I mean, you've just said that the Listeria platform itself is ahead of time, basically. I mean, what have been the hopes and stops and starts along the BCIT journey since William Coley?
Well, I think when you are using biologics, you need to make sure that you're controlling them. So of the over 453 patients that have received our platform technology, we did have one fatality. That's because the patient resisted or did not come back for their antibiotic. The other problem is our predecessors would give antibiotics at 72 hours. And our chief medical and scientific officer, who's one of the founding scientists, actually did a trial and showed that immune response occurs at an hour. And if we shut down with antibiotics, the biologic infection at 4 hours, there's still the same immune response, but the biologic infection doesn't get a chance to take hold. At 72 hours and longer, the way biologic infections work, especially around implants, is they start to build a biofilm on top of and layer on top of foreign objects, because the foreign objects are an easy target for them because they're not being penetrated by the immune system. So as the biologic infection gets caked down with more and more layers, it becomes much harder to get that biologic infection out of the body. And that's why when patients have implants and you're going to do some procedure, they ask if you have implants because they want to make sure that there's no risk of infection. And so the longer a body gets exposed to the biologic infection, the more detriment it could occur. And that's why we have this very clear protocol. Matter of fact, when we went to the FDA to do the clinical trial, they said, hey, wait a minute. This is a biologic infection. What are you going to do about it? And we had the study that showed that we could shut down the shut down the biologic infection while the immune response kept trucking. So the trial went really well. We had very few side effects. There was one infection in a port. So a lot of cancer patients have a port that because they're having medications so often, that port had not been cleaned out and the port was infected. They removed the port on this patient and the infection was gone. Out of the 41 patients, that was the only one, and it was corrected very quickly. The other side effects, as I mentioned earlier, are chills and slight fever, which compared to these 9 months of chemotherapy is it's refreshing that the side effects are so minimal.
Yeah, refreshing and necessary. I think many people we speak to on the pharmaphorum podcast, it's finding an alternative to chemotherapy because the toxicity there, as you've been describing, it's inhuman, pretty much. Finally, Paul, as we bring our conversation to a close today, in your opinion, what does the horizon look like in 5 to 10 years for the BCIT space?
So I agree with you that chemotherapies are inhuman. And, I think 150 years ago when they were bloodletting, they thought that was a good idea. It is my life's mission to improve the outcome and overall survival of just this small pediatric cancer, osteosarcoma. The number of patients and family members I've met who've been affected by this disease. But what if we could get rid of chemotherapy for this one small cancer? Anderson Cooper did a 60 Minutes article and showed one of our patients, patient number 19, Christine Ohm, getting her first injection. And she rolled up in a ball and was very reactive. And what it showed me is the real PTSD those 9 months of chemo, because as Anderson Cooper voiced over, the side effects, the chills and the slight fever went away in a few minutes. But the chemotherapy is horrid. And so if we can trick our body into using its own system by introducing a really aggressive biologic infection, but then killing it 4 hours later and firing up the immune system to go down and track those little micrometastases that are trying to kill us. And we have cancer in us right now, Nicole, you and I do. But it's our immune system that identifies it and kills it before it takes hold. And so that's what we're trying to do with these patients. And it's my life's work. It would be a life check if we were to be successful in osteosarcoma. But what if we're successful in other solid tumors? You mentioned unmet medical need earlier. There's still unmet medical need for breast cancer. In the United States, 40,000 women, majority women, are passing away of breast cancer every year. We can do better. Other solid tumors, we can do better. We started this company to do good, as you mentioned, and we will continue to focus on the unmet medical need, but it's an opportunity to do good and do well. And I think that's what's changed over the years as we've added indications, as we've added technology. And that's why over the next 5 to 10 years, back to your question, and I am from Washington, D.C. I wasn't trying to avoid your question, but I really hope we can get rid of chemotherapy. Or if we do, that we deliver it in a much safer way. Our other platform technology in ADC, antibody drug conjugate, which is really hot in the biotech development right now. It's an idea where we take a targeting ligand, I describe it as a cruise missile, and it has payloads. And those payloads could be chemotherapy, they could be monoclonal antibodies, but we wrap those payloads, especially chemotherapy products, in silicone. It's like bubble wrapping something very toxic, and then attach it to the ADC with silicone. The cool thing about silicone is it gets broken down by pH, and cancer has a lower pH level. So we can deliver these packages, or cluster bombs, as I describe them, into the cancer environment without affecting the rest of the body. That lower pH or higher acidity eats away at that coating, and it delinks the payload from the ADC, the cruise missile, and drops the payload right in the cancer environment. I describe it sometimes, Nicole, as a mover that's moving a piano through your house, but they bubble wrap it first, right? So they're not banging the walls, they're not affecting the piano, and you can also bring a lot more pianos in at the same time because it's safer.
I like that analogy. Bubble wrap piano, cruise missiles, and finding a safer alternative or method of delivery of chemotherapy. Thank you very much for your time today, Paul. It's been a pleasure.
Thank you, Nicole.
And that concludes another episode of the pharmaphorum podcast. You can find more information about this episode, including a download link and information about previous installments at pharmaphorum.com/podcasts. The pharmaphorum podcast is also available on Apple Podcasts, Spotify, Overcast, Pocket Casts, Podbean, and pretty much wherever else you download your other podcasts from. Just search for pharmaphorum and follow and hit subscribe. Of course, don't forget to visit our website itself, where you can sign up for daily and weekly news and analysis bulletins. And do follow us on Blue Sky and LinkedIn at pharmaphorum. That's all for now. Thank you for listening.